I'm Dr. Joshua Grenier, and today I'm going to talk about dental implants. They are phenomenally successful. Many studies say that they're 90+% successful on healthy patients, but things can go sideways. I'm going to get into some of the things you need to watch if you're a patient or a practitioner that is interested in placing dental implants. Local risk factors, what those problems are, what to look for, systemic issues, and some of those may even surprise you. And as always, infections and biofilms, which can cause rapid losses of implants, both in the mouth and other places as well. And of course, how you can mitigate those risks. There was a very interesting paper that came out. It was a Monte Carlo simulation. And what this showed is that it's not a single factor. There's certain factors that when combined create an increased risk more than the sum of their parts. And these follow exactly what you might think, where if you have a patient that not just smokes, but also has periodontal disease, bone loss, they tend to have a much higher degree of failure. And it's the same thing if you with short implants. If you have short implants, that will increase your risk of failure. But if you have short implants and periodontal disease, it's even worse. So what that really shows is that when you really run into trouble, again, it's multifactorial. You may have a local issue and you may also have a systemic issue. And these types of systems are very hard to predict. I've seen implants that are placed on the same patient at the same time, right next to each other. One will succeed and one will fail. So a tiny difference in the starting point can create a completely opposite result. And it's not that it's even more complicated than the environment. There are specific genetic traits, and just one of them has been determined. It is an interleukin, IL-1 genotype. This creates a pro-inflammatory cascade that predisposes patients to not just implant failure, pericoronitis, or periodontal disease, but really what we see is that implant failures tend to be clustered on certain patients. Half of failures occur on a third of patients. So the fact that the patient has had a failure before greatly predisposes them for additional failures. They just have a propensity towards bone loss. And there's many different reasons for that. There are local risk factors. When you place an implant, it needs to go in the bone. And anything that adversely affects that is going to have a poor effect. The quality of that bone plays a huge degree. The majority of failures occur in soft bone. Type 4 bone is roughly the density of styrofoam, and it's usually found in the posterior maxilla, the upper jaw. It's not as vasculature, it doesn't have the same blood supply as higher quality bone. It's softer, so the implant may not be as stable. And not just softer bone, but you also see increased failures when there's an infection in the site, or if you place an immediate implant, or if there's a bone graft in that site. Anything that means that bone is not of the highest quality makes it less likely implant is going to integrate successfully. Finally, short implants. And there's a couple of reasons why short implants or thin implants are less successful. They don't have as much surface area, so they're not as stable, so they may fail later. But not just that, but the reason why short implants are placed is because the bone isn't as thick or as tall as it needs to be. And anytime the bone is insufficient, it means the walls don't have thin bone, means there's not a great amount of blood supply. So that implant is more likely to have recession or an early or late failure. Finally, and this is a big one, surgical trauma or overheating books, and it can happen very quickly. The number that's always cited is 47 degrees Celsius for 60 seconds. But in actuality, especially if you're drilling in very hard bone, with dull burrs. It can get incredibly hot, over 70 degrees or over 100 degrees, boiling hot in worst case scenarios. So that's why it's best to have copious irrigation. Even chilled irrigation is a good idea. Now, lack of primary stability. That means when the implant's placed in the bone, it's not rigidly fixated. It's actually going to get a little looser over the coming weeks. So if it gets loose enough, it's likely going to fibrose. Scar tissue is going to form around that instead of bone. Some of the reasons why this happened are over preparation. It was simply prepped too wide, or more commonly, it's possible the practitioner became indecisive as they were preparing the bone, and this created some wobble in the site, and this led to preparation that was too wide. Or perhaps the implant was placed in an immediate implant site and didn't get the ideal amount of rigid fixation. Also, certain implants have more aggressive threads than others, so some just don't bite into the bone and stay solid. Now, the theory is that any type of movement after the implant is placed is going to lead to that scar tissue and ultimately a fibrous integration where firm bone is not found around the implant. In modern implants, this happens less and less. Now, contamination of the implant, and it doesn't take much, especially if the patient is not completely healthy. The contamination can happen from outside of the mouth. There's certain bacteria. Staph aureus is a cause of implant failure and can cause catastrophic results when found in the bone. And there could be an infection within the site itself. It could be very poor quality bone, have a residual granuloma. Again, this is more commonly found in immediate implant cases. There could be bacteria found within the mouth, especially in periodontal patients. It could be inadvertently introduced to the site. There's a lot of bacteria in the mouth, and that's why you see improvement in implant results whenever measures of sterility or using antibiotics, controlling the surgical field, even using a pre-op mouth rinse, all increase implant success rates. Now, another factor is related to operator experience. When the bone is accessed, the ability of the practitioner to efficiently create a broad-based, full-thickness flap, deliver the implant efficiently and quickly, and suture everything closed in an efficient manner is going to reduce the dry time of the bone. It's going to lead to a much better surgical result. It's going to lower the duration of the surgery, and you're going to be more likely to get incision line closure. Irradiation of the site, you don't generally see this in practice, but in theory, if somebody receives 50 grays of radiation, it can have a drastic effect on bone marrow. And this is important for extractions as well. It's not a forever thing. It does last. You may need roughly a year medical consults, but you can expect this can be an absolute contraindication for these types of surgeries. Now, systemic risk factors, patient-related conditions, it's not only a local factor, but it's the ability of that patient to respond to that implant being placed and hopefully tend towards bone actually being created around that implant. So smoking, everybody knows it's a major risk factor for complications, not just in dental implants, but in hip implants, knee implants, all implants. Smoking is a huge risk factor. It greatly increases your chances of having problems. History of periodontal disease, again, it's absolutely huge. This is a no-brainer. It's going to increase not just your chances of having early failures, but late failures as well. Similar bacteria that are found on teeth that cause them to fail are also found on those implants unless hygiene is meticulous. Diabetes, everybody knows diabetes, especially if poorly controlled, can lead to a huge variety of problems. Poorly controlled diabetics, implants can place very well on healthy folks, but if not healthy, you could have a ton of issues. So it just leads to the importance of a thorough medical history. But there are some other medications too. SSRIs been shown to greatly increase the chances of having issues, roughly doubling them, if not more. And the thought is that osteoblasts may use serotonin as a neurotransmitter. Nobody really knows for sure. And proton pump inhibitors. This is a little surprising here, but they have another doubled risk of inflammation. Now, osteoporosis and bisphosphonates, this is classic. We all know that IV bisphosphonates are an absolute contraindication. Also, some very high amounts of oral bisphosphonates, especially if combined with high dose steroids and anti-angiogenic medications, can also lead to, can also be an absolute contraindication. Now, osteoporosis alone isn't an absolute contraindication, but leads to problems. You're more likely to once again have failures. Now, this is another surprising one, vitamin D deficiency. I live in a northern latitude, so you see these kinds of things. A lot of folks, especially elderly folks, have issues. And you may see that they are treated for vitamin D deficiency, but you can expect a greatly increased level of implant failure rates. We're talking either double or triple your failure risk. So it's becoming more and more common that if a patient is showing risk factors of vitamin D deficiency, to perhaps make sure those levels are optimized before implant surgery. There's many other systemic risk factors. There's many, any kind of immunosuppressive condition, age, and then finally, and this is more of a failure after it's placed, just bruxism. People that tend to clench their teeth are more likely to break what you put in their mouth, and they're going to cause you issues. Poor oral hygiene, very often the same reason that caused the patient to lose their teeth can cause them to lose their implant, especially if it's periodontally related. So lack of compliance, lack of oral hygiene, fictitious habits like smoking are going to cause continued risks, peri-implantitis, bone loss around the implants, and ultimately long-term failures. Biofilms, another reason why implants fail, and this is more of an early type, is that the very surface of implants is hospitable to microbes. It's very rough, and they can live on it extremely well. And once a biofilm forms, it's incredibly difficult to get rid of. So, especially if it occurs during the initial healing phase, it can not only destroy bone directly, but it can prevent osseointegration right off the bat. And you will see pain, swelling, often mobility of the implant very quickly, within a month or so. In some cases, it's very rare, especially in the dental field. In traditional, you would just remove the entire implant, irrigate it, regraft, and maybe attempt it later. In hips and knees, it's possible to try to treat the infection, but the implants are much larger. The problem is, once a biofilm forms, and not all infections are created equal, there are some that are incredibly virulent. Some involve fungi, staph aureus. There's many different types that can cause different failure patterns around implants. But once a biofilm forms, it's incredibly hard. It's resistant to common antimicrobials. It's not like a planktonic or a free-floating bacteria. These are hardened fortresses similar to the ones found in periodontal disease, something that we're all very familiar with. Periimplantitis you see all the time, and in some cases, if severe enough, bacteria can start to resemble osteomyelitis on x-rays. In catastrophic areas of failures, and it could be because both of them are caused by Staph aureus in some cases. Fibrous encapsulation, this is certainly possible where an implant can be placed. It may remain firm for a long time, and then an implant can just not form around the implant. And it's referred to as just a non-infectious failure. And it could be that the body's simply encapsulating the implant, and you will see simply a failure of the implant to become fully integrated. And it may be somewhat subtle. It may not show an extreme degree of mobility. Now, these complex failures, it's not all implant infections are created equal. They can involve a wide variety of bacteria, even fungi. And in prosthetic joint infections, these are very difficult to eradicate. And it's the same thing with dental implants. So, how do you avoid this? There's a few options to mitigate your risk of having these types of problems. The key thing, what it all starts with, is having a thorough medical history, a thorough evaluation, and proper case selection, proper patient education, and then finally treatment planning. Now, you have some ability with habit modification, especially smoking cessation. Alcohol can also cause implant failure as well as other social habits. And then finally, medical management, glycemic control and diabetics, ensuring proper nutrition post-surgery, ensuring that patient's well taken care of, appropriate antibiotic prophylaxis both before and after, and controlling vitamin D levels. And finally, controlling active disease, especially in periodontal patients, which we see very often. Yeah, and this is a no-brainer. Within the surgical protocol, just basic surgical principles, aseptic technique is going to reduce the amount of failures you will have. Copious irrigation, controlled speed, using sharp burrs, chilled liquid, chilled irrigation, gentle handling, planning the surgery in advance, guiding the surgery is going to help because it just reduces the amount of time that the patient is in the chair for. And that can only be a good thing. Grafting, when indicated, there's a variety of substances out there. PRP, PRF can also help the patient heal. Osteodensification and stuff like that can help compress the bone and achieve greater initial stability. And that's going to, all these techniques put together are going to help achieve success when otherwise you might have had a failure. Finally, how do you load these restorations? Ideally, you want to optimize the health first, do the surgery perfectly, and then finally determine how you're going to load them. In some patients, especially immediate, you may want to wait an additional amount of time depending on the patient age. Their maintenance schedule is extremely important. Determine how often they come in, how they're monitored to avoid problems. Finally, especially for larger implant cases, designing an appropriate prosthetic based on their occlusion, based on their bite, splitting them together, and trying to plan based on the patient's risk and their individual profile. So the key takeaways, very simple, but you do need to evaluate the risk factors. And there's some out there that may surprise you. So proton pump inhibitors, SSRIs can all lead to problems. And then optimize the patient condition as best you can. And if you're unable to, you may not want to proceed with the case. And never forget occlusion and properly engineering this case So you're less likely to have prosthetic issues down the road. And finally, maintaining these cases so they can be preserved as time goes on. All right. And that's it. If you have any questions, certainly contact me. And thank you very much.